for those just joining. I'm just giving a couple of moments for people to join from the lobby before we get underway, and then we will get started this morning. Okay. Great. I think we're going to get underway. I'm sure we will be joined by more colleagues as they get themselves their morning coffee or tea before they join us. But I will get us underway so we can make sure we get you all finished before the rest of your days get underway. So good morning, everybody. I'm Sally Warren. I'm the Director of Policy here at the King's Fund, and I'm absolutely delighted to welcome you to today's breakfast meeting where we're celebrating the 75th anniversary of the Windrush generation, where we'll spend the next hour and a half reflecting on the contributions of the Windrush generation and their descendants to the NHS. The story of the NHS and of Windrush and migration is entirely intertwined, so I'm really proud that this is the first time the King's Fund has really properly celebrated and acknowledged the Windrush anniversary. Health think tanks spent a lot of time talking about NHS anniversaries, but this year we've wanted to really reflect on a broader history of what makes our health and care system the system it is today. So I'm really delighted that we're able to share this time with you today. This week, we're also launching a new online exhibition from the King's Fund Library team, which looks at telling the story of the Windrush contribution to the NHS and has a strong part of lived experience throughout that exhibition, as well as telling the history. And we'll be bringing that throughout today's session as well, where we've got people reflecting on their and their families' experience of working with the NHS since the time of Windrush. So I'm really delighted to be with us all today. I'm particularly delighted to be joined by an amazing set of panelists who we'll be hearing from throughout this morning. So really grateful for them for giving their time this morning. So we're joined by Charles from the Caribbean and African Health Network, Habib from the NHS Race and Health Observatory, Cheryl, who's a former NHS midwife, but also part of the Caribbean Nurse and Midwives Association. And we're also joined by my colleague from the fund, Shilpa, who's a fellow that's been doing a lot of our work on inequalities within the NHS workforce. So we'll hear a bit more from each of those panelists in terms of introducing themselves, and they'll be giving opening remarks. Then we'll have a bit of a panel discussion, and then we'll have plenty of time to have questions from you all as an audience today. And in terms of the questions, we're using the Slido function, so please do pop any questions into the Slido chat, and you can also obviously upvote other people's questions, and I'll try and pick the most popular questions throughout the morning. You also, if you'd like to, when you get to asking questions, you're more than welcome to pop your hand up, and we'll come to you for you to ask a question in real life, well, as real life as we can be on a Teams virtual session. By the time we get to Q&A, we will re-enable people's cameras and microphones, so we'll be able to see and hear you if you are asking a question at that stage. But at the moment, your cameras and mics are disabled, just to make sure we don't get any interruptions when our panelists are giving their opening remarks. The chat function has been disabled in this session, so any questions through the Slido, please, rather than through chat. A few other bits and pieces of housekeeping. You're very, very welcome to tweet throughout the morning. The hashtag is hashtag, sorry, my teeth are not yet in this morning, hashtag Windrush75. A few other just reminders. You would have had this in your joining instructions, but we are recording this session, and by joining this session you are giving permission for any contribution you make to be part of that recording and shared by the King's Fund afterwards. So any contributions are obviously therefore public. We do expect to have some journalists with us today, so any comments or questions you make would also be on the record, so just for people to be aware of that. But I think that is the main part of the housekeeping I need to set out before we get underway. So I think we should go straight into hearing from the panelists today. As I say, we've got a really great panel full of huge amounts of experience. And I think throughout the morning, what we're going to be hearing more about is the persistent trends in the lived experience of those people who are working in the NHS as part of the Windrush generation and their descendants, the disparities that we see in employment and working conditions faced by BME staff, and that in the context of the UK's continued heavy reliance on international recruitment to plug health and care workforce gaps. I also hope that we'll hear some hope as well, kind of what is it that we can do better in the NHS? How can we better ensure that the working conditions, the environment that we create in the NHS really allows all of our staff across health and care to thrive and be their best and to progress to their absolute greatest potential. So I hope that this is a celebration that's honest and reflects the challenges and the difficulties, but also how we can make sure the next 75 years feels very different to the last 75 years. So with that kind of overall scene setter, I'm going to ask Shilpa to kick us off amongst the panelists. So we'll hear from Shilpa, and then, as I say, we'll hear from all of the panelists. Do keep popping questions into Slido as we go through, and we've got plenty of time at the end to have that more interactive Q&A discussion debate with all of you who have joined us this morning. So thank you very much, and Shilpa, over to you.
Thank you, Sally. So good morning, everyone. I'm Shilpa Ross. I'm a policy fellow at the King's Fund. I'm really honoured to join you today, which marks 75 years since the arrival of HMT Windrush, carrying 492 passengers from the Caribbean. They were answering Britain's call to help fill labour shortages following the Second World War. And in 1948, the newly established National Health Service simply didn't have enough people, and nurses in particular. Many Windrush passengers went on to work in the NHS, which needed significant numbers of people to fulfil its ambition of helping everyone who needed healthcare for free. So in the year of the 75th anniversary of the NHS and the arrival of the Windrush, as Sally said, it's fair to say the two things are very much linked. The NHS of today has been shaped by the essential contributions of the people of the Windrush generation. And of course, the NHS still has significant workforce shortages. Data shows there are 124,000 NHS vacancies. So just like the recruitment campaign 75 years ago, we are still looking overseas to fill NHS workforce shortages. Overseas recruitment from outside of the European Economic Area has really grown. It's really ramped up since 2018, 2019. More than 1 in 6 NHS staff has non-British nationality. So clearly, the NHS cannot function without the people coming from overseas, which leads me to another part of the story, a sadder and more troubling part. So as you can see on the online exhibition, which we will be launching today, the working environment in the NHS for people who migrated in the Windrush era was not always fair and not always equitable, as well as experiencing the overt racism of patients and colleagues. Black staff experienced discrimination in their training and career development. People described being overlooked or having assumptions made about what they were capable of. So moving forward to today, the data shows Black and minority ethnic people who work in the NHS still experience an inequality. There is inequity in shortlisting and in formal disciplinaries. Black and minority ethnic people are more likely to report discrimination at work from a manager or a colleague, and less likely to report that their organisation gives them equal opportunity for career development. At the fund, we undertook research on workforce race inequalities and inclusion in the NHS, and there are some echoes of the discrimination described by Black people in the Windrush era in what Black and ethnic minority NHS staff describe in the NHS culture today. So, for example, I'd like to share what someone told us, and this is a quote. "I've got people who are managing me who are racist. My manager holds me back, stops me getting opportunities that are given to my white counterparts who are maybe not as experienced as me. So in that same piece of research, we looked at what is being done within NHS trusts to foster equity and a better sense of inclusion for NHS staff from ethnic minority backgrounds. We saw that there were interventions such as staff networks, making it easier to talk about discrimination at work, and developing ethnic minority staff so that they can gain the skills and be ready for promotion into more senior roles. Looking to the future, it's essential that the NHS tackles its long-standing issues with inequalities to ensure all of its people stay in employment in the NHS. Those are my opening remarks. Sally, am I passing back to you?
Yeah, brilliant. Thanks ever so much, Shilpa. A really sobering reflection of the current experience that many people have working in the NHS, but also kind of sign of what can be done to make a difference and improve the working experience. So thanks. I think that sets us off very well for this morning. I'm now going to come to Charles from the Caribbean African Health Network. Charles, it'd be great to hear your reflections on the legacy of the Windrush landing and generations in the NHS, and also the work you and your network do to really try and tackle and shine a light on the inequalities being experienced as well. So Charles, over to you.
Yeah, thanks, Sally, and thanks to you and colleagues at Kingsman for putting this on. And as you rightfully, acknowledged earlier on, and Shilpa, Ahmed on that, the NHS are amazing, NHS and the arrival of the Windrush, they're very much interlinked, and we're delighted, partners like yourself and many others are really giving the Windrush, the celebrations, the high profile, it requires. And yes, Charles Cockerill, Chief Exec for the Caribbean African Health Network. We were set up in 2017 on the back of a PhD study looking at why Black people tend to have poorer CVD outcomes. And you're right. I mean, we're so delighted that 5 years ago, we started planning to celebrate the 70th anniversary of, Windrush. This was when both Yvonne Cargill and Habib were working on the rest, and they, they put a call out that it would be good to have some high-profile celebrations. So, the planning was way underway. It was underway before the scandal broke out in the, Guardian and the other newspapers, and we're delighted that 5 years on, right across government and our public sector and others, that there's this mobilization to try and right some of those wrongs. It's brilliant we're able to celebrate the contributions that have been made. And yesterday I was privileged to be at Downing Street for the reception, and I think there's a wider recognition that it will take a while for those descendants as well as those who are rightfully entitled to compensation to have that. But for my organization, what we've been seeking to do is to shine a light on the health inequalities that is experienced by Caribbean African people. And what we say is COVID didn't teach us anything new, because even some of the stack rates that we were seeing from the data when it comes to COVID, we know Black women 4 times more likely, whereas during COVID, it was twice. If you were Black and you ended up in ICU, you were twice more likely not to pull through. So some of these have been there, and I'm sure when Habib comes in for the first time, they did the ethnicity, health inequalities, rapid review, which is amazing. And so being able to pull everything together. So it's great delight to be here for us to have a discussion about the contribution. And we're really excited and delighted that, our amazing NHS is the most diverse employer, not just in England, but probably across Europe. And there's a real commitment to make sure we can make some progress with all the issues that Shilpa highlighted earlier on. Thank you.
Thank you, Charles. It's really helpful, and good for you to remind us that a lot of the inequalities that I think we can quite often say COVID really brought to light, actually those inequalities have been there for for almost forever. So really great that there is now much more focus on it. But I think a key challenge for all of us as senior leaders in the system is how do we maintain that focus? How do we make sure that focus moves from focus to improvement and change rather than just awareness of the challenge? So I'm sure we'll come on to that later. So thank you very much, Charles. Cheryl, I'm going to come to you next. And at this point, I should explain, those of you on Teams will see that Cheryl appears to have the name Matthew Campbell this morning. Cheryl's joining, I think, from a nephew's laptop. So Cheryl is definitely Cheryl. There is no imposter syndrome going on here, but we weren't able to change the name on the screen. So just to reassure, it definitely really is Cheryl. But Cheryl, if you could introduce yourself and give us some opening remarks, that would be lovely. Thank you.
Thank you. My name is Cheryl Gregory, and I'm here representing both the Caribbean Nurses and Midwives Association, as well as the Nurses Association of Jamaica, UK, and that has been going now for 45 years. And that was formed in relation to the difficulties that Black nurses, particularly Jamaican nurses, experienced when they came from the Caribbean to serve in this country. I trained as a nurse, but I didn't work as a nurse. I went on to do midwifery, health visiting, and I eventually ended my career 7 years ago as a specialist nurse in sickle cell and thalassemia. All the evidence that Shilpa alluded to in her opening remarks, I have lived experiences and have had colleagues, and in my role as a member of the Nurses Association of Jamaica, as well as CNMA, and involved in giving pastoral care to the newly recruited nurses, I can confirm that the disparities, the inequalities still exist. But it is encouraging that at least now there's a pastoral care, and we thank the King's Fund and the Florence Nightingale organization and NHS England, who have helped to create the opportunity that pastoral care is given to these newly recruited nurses. So I think some lessons have been learned. The NHS have been my entire employers since I left school and started at aged 18 years. And there has been positive experiences. It's positive as an individual in career development, in entering a profession that allows you to grow and to contribute significantly in improving healthcare, not only for people that looks like me, but the entire population of the UK. And we have contributed so much. We really have been the backbone of the NHS, but sadly, we've not given the recognition that we truly deserve. And it's encouraging as well to see now that you have more representation at a higher level. It is slow, but at least we're moving in the right direction. And we have to give accolades to people like Sir Nigel Crisp, who identified and implemented a program to support the leadership program for people from ethnic minority. It would be nice to see for us to reach a point where you wouldn't have to have separate leadership program, it should really be a broad program that incorporates everyone. We shouldn't have a separate for BME. And until we reach the point where we have just one channel, then we will truly say that we've conquered the disparities. I could not have chosen a better organization to work with. Throughout my career, despite swimming against the tide, which also allowed me to develop the coping mechanism, you know, I loved my time in the NHS, and I would do it all over again if I had the opportunity. Sadly, we do not have as many students and workers from the BME background joining the NHS, which is a travesty. But the positive thing about that also is that there's wide representation in other areas of the NHS. And thanks to the King's Fund again for all the researches that they've done in highlighting the problem and bringing it to prominence. So it's a delight to be joining you today and to truly celebrate what we've all achieved together. And thank you for having me.
Thank you very much, Cheryl, and thanks for being so generous, for sharing your life experience. But what I really took from that is the absolute passion and joy you felt by being able to contribute to the NHS. Obviously, with aspects of that experience that you'd like to be considerably better for the next generation, but your commitment to improving healthcare and how proud you feel about the contribution you've made on that, I think really shone through in your remarks. So thank you very much. It's great to hear. Habib, we're going to come to you to let you have, I would say the last word, but obviously the last word in terms of the opening remarks, and then we'll be having much more discussion. So Habib, obviously you've already been mentioned in some of the conversations in terms of your different roles in over the last few years about really trying to highlight and shift to improvement being made right across the NHS. So I'm really pleased that you're with us this morning. So Habib, over to you.
Great, thank you so much, Sally, and it's great to be with so many brilliant people on the panel. My name is Habib Naqvi. I'm the Chief Executive of the NHS Race and Health Observatory and previous Director of the NHS Workforce Race Equality Standard at NHS England. And when I was thinking about this this session, three things came to mind, three kind of facts that were true in 1948. Firstly, that the country was focused on and well aware of the health inequalities that existed right across the country at the time. Secondly, the government was focused on resolving national workforce crises by going overseas and recruiting people from overseas. And thirdly, as Shilpa and others highlighted, there was discrimination within the workplace based upon race and ethnicity. Those three facts are still true 75 years later. And in fact, the notion, although I'm not from the Windrush generation directly, the notion of a parent or grandparent arriving during the middle of the last century with nothing but a suitcase, a few pounds in their pocket and a piece of paper with an address on it is a common story for so many of us. That was certainly the story for my dad in 1955, who came from the Punjab area of Pakistan and ended up in the winter of 1955 in Newcastle, which was probably a shock to the system for him. But the arrival of the Windrush and subsequent generations was really the new chapter for not just the establishment of the NHS, but for multicultural Britain. And with the establishment of the NHS itself, just as panelists have highlighted, we know of the issues that staff within the NHS, since its inception, from Black and minority ethnic backgrounds, have endured and continue to endure. And we see that through the NHS Workforce Race Equality Standard data, which is published on an annual basis. So less likely to be recruited from shortlisting, less likely to be promoted, more likely to have pay gaps, more likely to go through a formal disciplinary process, and less likely to find themselves around a boardroom table. So we know that those are issues, and that those experiences do not reflect the values, not just the values of the NHS Constitution, but perhaps the dream and the vision that so many had when they arrived to these shores many years ago. Yet we still know that these disparities are avoidable. And if organizations focus on doing things in a concerted way to tackle the inequalities that we see, i.e. having demonstrable and committed leadership, focusing on the data and the evidence, having data-driven accountability at an individual and organizational level, focusing on the communications and resources for this agenda, we know that the dial of inequality can shift. And the fact is that addressing inequalities, addressing systemic bias, addressing racism, is not only a moral imperative, but it also leads to organizational efficiency and savings as well. But more importantly than that, we also know that equity leads to better outcomes for our patients. And working in the NHS, of course, that is a fundamental point that we must remember. So in conclusion, I guess, summing up from my perspective, the 75th anniversary of not just the NHS, but of the Windrush, yes, it's an opportunity for us to celebrate all that's great about the NHS and about migration and the richness that it brings to all of us. But it's also a key reason, I guess, for us to renew our efforts to make our current workplaces more equitable and to make the NHS of the future more equitable for everyone.
Great. Thank you very much, Habib. Really, really helpful reflection on kind of the combined threads of our history over the last 75 years. And I think what we're seeing is a bit of a common theme, how we can and should be doing better going forward as well. So really, really helpful. Just a reminder to the audience, please do pop questions into the Q&A. We're going to have a bit of a follow-up with the panel now, but then we will be coming for more audience questions. So pop questions into the Slido, or at the point we open up Q&A, you can pop your hand up with a question as well. So I was just going to kind of follow up on a few things that kind of sparked from what the panelists have said so far. And Charles, wanted to come to you first, because you reflected actually your organisation is quite young. So Windrush 70 was the kind of the first bit, and you did reflect the amount of progress that has been made in those 5 years in terms of this is a different conversation, a different recognition of celebrating a contribution of a whole generation. So I suppose I'm interested in, if you could jump ahead to the 80th anniversary, what are your hopes for how far things might have progressed in those 5 years? So almost kind of what's your wish list for if we're all getting together in 5 years' time? What would you like us to be saying then about the current lived experience?
Yeah, thanks, Sally. So, I'm going to reflect some views of community, but also organizations. And then, how do we build on some of the amazing work, Habib, Yvonne, others have done, and some of the issues that have been raised. So I think from a community perspective, 5 years from now, there shouldn't be anyone waiting to have compensation, from the scandal that has happened, that has left many people, broken families, restricted and limited opportunities, and people not thriving as they should. Yesterday, one of the points we raised was the fact that, people should not have to rely on solicitors to get what is due them. They were invited to come and help build, what we have, which right across the world is an envy, a health and social care system with values Habib touched on, that is meant to be free at the point of access, and also, meant to, really galvanize communities together and reduce barriers. But we're not there yet. So that's where the community is at. But also, one of the big things we saw during the pandemic, which we've known about long ago, and it was one of the 5 problems why my organization was set up, is the lack of trust. Because what we have now, and even with some of the best will, and I'm sure, Cheryl or Habib will, affirm this, even where there are programs, there are people in my community that are suspicious it will really make any difference. Where people are suitably qualified for roles, you sometimes literally have to push them and encourage them, to really take that step of faith, because people have been knocked back so much. It isn't the same. And also the other thing to highlight, and I'm reflecting this because of some of conversations with people in communities, some of those we have within our health and social care system, or within care, they have wealth of experience. There are people who have migrated over here. Some have been refugees, asylum seekers. By the time they have the right to remain, they've seen or they've benefited from our care system, and they want to get into that. So they have wealth for that. Recently, I was speaking to someone who said, trained as an engineer, has a business management background, but really, amazed by the care system and wanting to go into that and probably into nursing. And I'm wondering, but my own personal experience, I used to, whilst I was studying as a migrant, I worked as a healthcare assistant, through my 2 masters, through the beginning of a PhD, which I wasn't able to finish, but it was just because it was amazing. So, 5 years down the line, I think for communities, the compensation stuff should be behind us, and people should feel that sense of there's a real commitment with all that is going on, and high profile receptions and celebrations, that trust, the system is interested in trust from community. I think from organizational perspective, then it's about us seeing a lot more visibility and support from the Ethnic Minority Nurses Association, whether it's the Jamaican one, the Nigerian nurses, and others, being able to make contributions. Because as great as our NHS is, one of the challenges is being able to tap into the wealth and the cultural, potential that we have. And Habib has mentioned the, the benefits of equity and the better outcomes. So 5 years down the line, we should have a system that equally values, others being able to make a contribution. And I think from a policy perspective, we would want to see a lot more, people from our backgrounds around the board table. We want to see, drop in the disciplinary rates. We want to see, people not being discriminated just because someone who is shortlisting can't really mention their names. And I think we need to have open, honest conversations around AI and some of the potential biases within that. Because Habib will tell you one of the things they've had to work on is the bias within medical devices. So if there is bias in medical devices 5 years down the line, if AI is to be at the center stage of a lot of what we do, we as a community need to be reassured, having been involved genuinely in conversations, that we are not going to be disproportionately impacted because, AI, we weren't part of that engagement. So I will leave it there for now.
Great. Thanks very much, Charles. And I think that theme about trust being hugely important, that entirely understandably, we need to be able to have a dialogue with the community to show that we're not just talking the talk here, we're walking the walk as well, and we mean it, and it will shift people's experience. But it takes a long time to build, to rebuild trust once it's been lost or not there in the first place. So thanks, Charles. Cheryl, I was going to come to you next. So I was really struck during your opening remarks that there was a real sense of hope for the next generation, and also a real sense of sort of the current generation really wanting to lean in and support the next generation to have a different experience, the importance of pastoral care. So I suppose I just wanted to hear from you, what are some of the aspects of pastoral care that you'd like to see happening? As you know, no doubt at the moment they're kind of islands of best practice, but what would you like to see happening routinely across the health and care system to mean that we really are shifting the current generation's experience about working in the NHS?
Sadly, it's very difficult offering pastoral care to nurses who have been newly recruited when we've not sorted out the problem of the indigenous Black nurses in this country. So it's almost like a juxtaposition, and it really is sad to have to say this. And if 75 years and we have not got it right, I am cautiously optimistic as to what we can achieve in 5 years. But to go back to your question, the nurses who have been newly recruited and requiring pastoral care, they're having the same issues in that their previous experiences have not been fully recognized. Many of them have left countries where they've been in senior positions, and they're coming here and starting at the very bottom. And the time that it's going to take them to move up, if we're having problems promoting the ones who are the homegrown nurses, how are we going to promote the ones who have been the newly arrived ones here? It's almost as if the clock has been turned back to 1948. What I would like to see is that, again, it's this unconscious bias that always rears its ugly head. And the discrimination is not also coming from patients. That's more subtle, but it's the very stark and open, really transparent discrimination that is coming from a managerial level. It is evident in our political legislations as well.
Thank you, Cheryl. Thanks. And that finishing on that point about management is really helpful segue for where I wanted to go next in terms of, I was going to almost give the same question to Habib and Shilpa, really. So in your remarks, you've talked about the overall kind of some of the data about the experience, but also some of the things that can be done to shift. So we know some interventions can work, but I suppose just stepping back for the individual interventions, what is it that you think we need to see from senior leadership across the health and care system, which, because, depending on different organisations, their current baseline, one intervention may well be more appropriate than another, but what is it that we need to see to have a sustained focus that actually leads to change here? Maybe I might come to Shilpa first and then Habib. And sorry, it's kind of quite a how do you solve the world kind of question, but if any people can answer it, I'm confident that Shilpa and Habib will be able to fix the world for us.
Such confidence. Thanks, Sally. So I think that's I'm afraid I'm going to have to say there isn't like one single magic bullet that's going to resolve all the issues that the NHS has with its culture. But for sure, there is a role that senior leaders can play in, and let's be frank here, most of those senior leaders being white, to step in and shoulder the burden that is faced day to day by people from Black and minority ethnic backgrounds in just being at work. I think there is, you know, more they can do to accelerate, you know, the push for unpicking bias where it exists in the employment of in the employment of people, and how they are cared for and looked after once they are in employment. I think looking across it all, you know, the data highlights exactly where leaders can step in and help, and this is about improving recruitment and processes within the NHS, supporting career progression. Like, really do it. It's good to say it, but really, you know, follow it up with some action. And you know, there needs to be accountability. So what are leaders doing to promote better inclusion of staff from Black and minority ethnic backgrounds, and to promote more equity in the system?
Right. Thank you, Shilpa. Really helpful. So Habib, your reflections on what it is that we need to see from senior leadership.
Well, demonstrable leadership is one of the key points that I mentioned before, and it's the model that we support and we endorse. But as Shilpa says, there's, you know, demonstrable leadership on its own, or any one intervention on its own, will not be able to kind of shift that dial. So, as I mentioned before, demonstrable leadership, data-driven accountability, resources, communications, and the critical element here is that all of those aspects, or what I call the pieces of the puzzle, need to be in place at the same time, simultaneously, and over a given period of time, which Harvard University says is around 5 years, before we begin to see that shift in the dial, before we begin to see the shift in markers such as the NHS staff survey and how people feel within organizations. So that's kind of the first point. The second point, I guess, is that every single person and organization are at different points on this journey. I remember back to when I was working in the Workforce Race Equality Standard program at NHS England, of a white male chief executive of a hospital trust in London, who really did walk the talk, as it were, in the sense that he demonstrated those key aspects on a daily basis. So he would tweet out virtually every day on issues around white privilege and around race and racism. He, as a chief executive, would turn up to new induction for staff within his own hospital. And as you can imagine, on some days that may be, I don't know, 20 new members of staff or 50 new members of staff joining at any one given point in time. But he wouldn't just stay there for the first 10 minutes of that induction program. He would stay there for the whole of that program. And when he talked, he would be very clear on issues around equity and inclusion, and would say, you know, my trust has a zero tolerance around race, racism and discrimination, or discrimination of any sort. And if that's not aligned to your values, then there's a door. This organization isn't for you. So having that very clear message right from the outset, with that very clear demonstrable leadership, is essential, because at the end of the day, we want leaders to be leading all of the people all of the time, and not leading some of the people some of the time in some places. And so making sure that we have that demonstrable leadership at not just at individual level, because we're all leaders, but also at organizational level, also at institution level, society level, government level, dare I say it, is absolutely critical.
Right, thank you very much, Habib. Really helpful reflections. And yeah, complex problems very rarely have simple solutions, do they? So this is about leading constantly and recognizing that complexity, but still trying to move forward. So really helpful. So we're going to move to the Q&A part of the session, which I think should mean that people will be able to raise their hand, and if we call on you, you will be able to turn your camera on and your microphone on now, because we've not been allowing that up until this point. But I'm going to take a couple of questions from Slido to start us off, and then see where we get to with how brave people are feeling to pop their hands up. So one question from, we don't have the name of this individual, but I think this links to some of the questions around trust that we've been talking about this morning. So does the NHS need to engage more widely with tackling racism in the wider community? And I wonder if I might come to Charles first and then Habib on that, and then see if others want to chip in. But does the NHS have a role kind of beyond its role as an employer, if you like? Charles?
Yeah, thanks, Sally. And my response is yes, yes, yes. You know, there is a role, but I think before attempting to do anything, what is this racism we're talking about? You know, do we really hear from people with that lived experience? Because unless we all on the same page, then there will be some desperate action and we will be all over the place, but there will be nothing sustainable and nothing, you know, really targeted. So, you know, various programs have happened before. So we need to, and the NHS does have an influential role. Now that we have 42 integrated care systems, all of them consider themselves, you know, as anchor institutions and the various components coming together. So there's a real opportunity to do something different. You know, from a legal perspective, there is a role there. You know, there has to be that commitment to tackle health inequalities. Each of the 42 systems are meant to have a people and communities plan, you know, and therefore it's really important. Thankfully, we've had 2021 census data. We know it's already out of date because of all the migration and the movement. But unless we can have some of those open, honest conversations about what does racism look like, what does racial discrimination look like, then what we're going to do is to leave the debate within media and the public space. And then some people shine away from it because they don't know what to do, because there isn't any agreed. So we want to see things happening at system level, that's system-wide thought leadership, you know. So just like Habib mentioned, you know, we need more allies to say we really want to understand this, and how racism plays out in an acute setting will be very different from a primary care network. It will be very different from, you know, a mental health setting. So we need to, it's very complex, and therefore there's a need for a whole system approach to really unpack and get under the skin what it looks like. And then when we sort of agreed, because, you know, we have the privilege of facilitating the Greater Manchester Mayor's Race Equality Panel. And then there's been a lot of debate around institutional racism, structural racism, you know, and systemic bias, and what means what. You know, we can have all these discussions, like Habib mentioned, you know, and 5 years, nothing would have shifted. But we need to start from somewhere. From all accounts, there is will. How do we then, you know, capitalize on that? And then for all those who, following the murder of George Floyd, put out Black Lives Matter statements, come around the table at your locality, whether you're a business, whether you're a public sector body, whether you are a national charity. Let's have those discussions about what the lived experience of racism, structural discrimination, systemic bias, what does that look like, so that we can begin to work at a system level. Thank you.
Thank you, Charles. So a clear agreement that yes, there is a role for the NHS in its wider community, but also the real importance of listening carefully and closely to staff experience and community experience to really understand what the problem is that we're trying to solve. So thanks. Habib, did you have anything you wanted to add on that question?
Well, just to emphasise the points that Charles has made, because Charles is, as always, absolutely right. So racism is a global system-wide issue that requires a global and system-wide response, and that's why, yes, the NHS has a role to play, but it's not the only enabler for equity. But just as Charles said, I'm positive on the establishment of ICSs, because I think that's one theoretically that's one good step in terms of bringing together different parts of society to tackle this issue. But of course, you know, the first step to any change is to acknowledge that there is an issue or a challenge to tackle. And so where, in fact, I was on a panel yesterday with the King's Fund on a CVD conference, and a question was asked by the audience, do people know the difference between equity and equality? And my response was, they may know the difference, but they may not want to acknowledge the difference, because this is about, people do not want to give up their power and their privilege. And that's some of the basis for the inequalities that we see. And that's one of the reasons why the NHS Race and Health Observatory was established just over 2 years ago, not just to focus on the surface level issues around inequalities within our communities and within the workplace, but to focus on what we call the causes of the inequalities that we see. And that includes structural racism, interpersonal racism, and how those two come together in terms of institutional racism.
Thank you. Cheryl or Shilpa, was there anything you wanted to add on that question around the NHS reaching beyond its employment role into the community? It's fine if you don't want to. But...
I think I'd say yes. I think yes, the NHS as an anchor, as an influencer, can help push forward these these discussions and in the sort of context of integrated care systems, and talk about the impact of systems on people's health and how people are able to live happy and healthy lives free of racism. I think absolutely the NHS can be a key influencer in that.
Most definitely. As the employer of the highest numbers of BME people and a universal service where you have every class, every race using the service, I think it is essential, and they're well placed to influence.
Great. Thank you very much. Great. I'm going to ask a couple more questions from Slido because I don't at the moment see anybody with their hand up on screen, but if anybody does want to, please do. I'll keep my eye out for a yellow virtual hand. And one pops up at this point. Great. So one of the questions I wanted to ask, and I think I probably do need to start with Habib on this one because it's a sort of data and facts question. So we've spoken several times this morning about the workforce race equality standard data. Could you just give us a bit of a flavour of what is the current data telling us, and in particular, what does that tell us about the successes to date of how the RES has focused attention and enabled people to see progress, but also where we still have some challenges? So I know there's a huge amount of data and you could probably do a 2-hour talk on what the data tells us, but that kind of top line about progress, successes, but also where we've got much more to do.
Sure, yeah, absolutely, Sally, and probably a 2-day talk rather than a 2-hour talk. But I think just to highlight where we are on workforce race equality, we know, as I said before, that when we started on this journey back in 2015 on the workforce race equality standard and the collection of the data for the very first time and building that into the NHS standard contract and into regulation, we for the first time were able to have this this level of data and insight, which told a very stark story around less likely to be recruited, as I said before, from shortlisting, less likely to get promotion, more likely to go to formal disciplinaries, less likely to find themselves at board level, in board level positions, more likely to be bullied and harassed, as the NHS staff survey shows. So these are very critical indicators, and over time what we've seen is slight improvements in some of those indicators. So the disciplinary metrics are improving, the board level representation metric is improving. However, there is a kind of a health warning to the data as well, because what we also know and what we hear so often is that sometimes organizations are able to manipulate the data in the way that they do things. So within the workplace, individuals from a Black and minority ethnic background can still go through what very much feels like a disciplinary process but may not be classified as a formal disciplinary process and may not appear, therefore, within the data that's collected on an annual basis. With board level representation, we know that there is an improvement, and there has been over time, but we need to split out the non-executive directors from the executive directors to look at exactly where those improvements are happening. And historically, those improvements have been happening within the non-executive director areas rather than the executive director areas. And we haven't progressed significantly enough in terms of, for example, the number of chief executives from a Black, Asian, or minority ethnic background across NHS trusts. So there is a lot more work to be done. And what we've seen, particularly through COVID, is the experience of Black, Asian, and minority ethnic staff within the NHS, which I believe has been reflected in the latest NHS staff survey, i.e., less likely to feel included within the workplace, more likely to report the experience of bullying and harassment and victimization. And so there is, of course, always a lot more work to be done.
Thank you, Habib. And I just thought I'd give the panelists just a chance to think, is there anything from the latest RES data that really resonated with you, either from a really pleased to see progress being made, or where you really thought, oh, this one seems really hard to shift? So if you had any particular reflections, Shilpa, I might start with you, if that's okay.
I can't add much to what Habib has already laid out there, but I just think it's worth saying it's incredibly helpful to have a data set such as the RES, because how else would we know and draw attention to where the NHS is struggling with its where the NHS is struggling to ensure that there is equity. It's good to have the data set, but it's a shame that it does also show through that data set how long it takes to shift the dial. So going back to something we were just talking about, it does take time to see really sort of significant movement across those metrics.
Great. Thanks, Shilpa. Charles or Cheryl, is there anything particular that stuck with you? If there wasn't, it's absolutely fine.
Yes, what I would like to say is it is good to have the representation, but even at the higher level, the BME staff at those levels are still experiencing problems. Do they have the confidence to speak out? Are they penalized when they try to address difficult issues? So it's fine being in the position, but it's the support that you have and your experiences when you're in those positions.
Thanks, Cheryl. Charles?
Yeah, and just to add to what colleagues have mentioned, it's great to see progress, from that data perspective. I think whilst we continue to see that progress, and long may continue, it's then looking at building on what Cheryl mentioned, the experiences, because sometimes I've come across some of those senior leaders who feel very lonely, very isolated, and some who do really well at that top level need to have mentors, need to have that 360 peer support. So let's continue to see the data move in the right direction in terms of reduction in levels of disciplinary, higher representation, and more people are on the board table. But then let's not ignore the fact that if we want people to function at that optimum level around those spaces, then it's about the support package we put in place and making sure that we having those checks and balances.
Great. Thank you, Charles. Really, really helpful points. I'm going to come to the virtual floor now. So we've got Marcia and Paulette have both popped their hands up to ask questions, so I'll probably take both of those questions at the same time and then come to the panel. And then we have got a great question on the slide about trust and accountability, and the two of those things together. So we'll come back to that Slido question perhaps towards the end. But Marcia, you've been very patient waiting with your hand up.
That's absolutely fine. Thank you so much. I just want to say this is great conversation to be having, but I just want to make a comment before I ask my question, which is, while the Windrush, and I'm a child of the Windrush generation, is a marker in terms of Black people being in this country, they have been here for hundreds of years. I think we have to remember that, and sometimes that is forgotten. And I've done some work in that area where I've identified the contributions that Black people have been making for a significant period of time. But my question is in relation to the point that was made before about leadership and what does that actually mean at a strategic level, so that impacts operationally. And one of the things that I found particularly frustrating is the fact that George Floyd's murder was a marker in terms of a lot of talk about how things must change. And I must say the organisation that I work for has actually issued a very clear statement regarding the fact that if you're a racist, don't work here, and I welcome that. Nevertheless, what I found frustrating is the lack of sanctions, meaningful sanctions when people act in a racist manner. And I did some research recently, and all it talks about, everything that you look at ACAS, you know, oh, you must have policies, you must have procedures, you must have, all those things really do make a difference because they set the tone and culture of the organisation. But ultimately, if you don't have meaningful sanctions, which are not confined to disciplinary action, they should go right up to the ultimate, which is dismissal. And if you are a regulated professional, referral to your regulator, that people who look like me, a Black person, see that you mean business. I get a little bit tired and weary of, well, you know, we're going to take action. We need to have case studies that show the impact and difference when people behave in a way that actually undermines and excludes others who just want to get on and do their job. Well, if nothing happens, people fail to report. We live in a racialized society, no matter what people say, and yes, we can influence and change, but we're working within a political system at the moment where very subtle messages are being given about how people are different. So in the meantime, we need to make sure that we work in organizations whereby we feel that if somebody acts in a way that is, you know, not conducive to good working relationships because you are treating someone differently, that appropriate sanctions are taken. And I can't find anywhere where we've got evidence of that being something that is being pursued actively. So I'd like to know what the panelists think. Thank you.
Great, thanks very much, Marcia. And that, I think, links really well to the question I was hinting at about trust and accountability, and actually how can communities have trust if they don't see any consequence for kind of any consequence if progress isn't made or where the specific instance happens. So really great question, Marcia. Paulette, can I come to you as well, and then we'll come to the panel with to get their thoughts. Paulette.
Oh, hello, good morning. I'm Paulette Lewis, the president of the Caribbean Nurses and Midwife Association, and also a non-executive director, 2 boards across London. First of all, when we talked about boards and non-executive directors, I think you're quite right. How brave are you sitting on a board to feel confident that you can challenge? And again, going back to habits and the res data, how are we using the res data at board level and really interrogating that? Saying that you want your organization to be non-racist is one, but putting the action in and look at the outcomes are totally 2 different things. So words is one, but action and outcomes has to be something which I think Marcia is just talking about in looking at, so how are we doing? Because sometimes the operational issues will sometimes overcloud some of those softer things as workforce issues and so forth. So as a non-exec director, I know my board, the listeners, I'm always asking that question. There is no organization can function without its staff. And so therefore the staff is the organization, and somehow the emphasis on staff and workforce and the outcomes and what we're experiencing probably is not highlighted as much as other issues. And I do understand there are many issues that one has to address as a board. So I just thought I'd bring that in. But the accountability of the board is that, yes, we'll say, yes, this is what we want. Yes, no races. But the issue we have is how that is filtered down on the ground. Because most of the issues that go to NMC, and Habib and NMC will say, it is about the junior managers. How prepared are they to manage staff, to understand cultural transition and competency, when some of them are clinically experts, but not managers of people, and they themselves are not being managed and pressured. So it's very easy to say you're a good clinician, so we put you in a role, and that's where a number of the issues. I've done a lot of work around the international recruits, and as I feed back to a number of chief nurses who have been very good in working with the Caribbean Nurses Midwife Association and feedback what we have found, and they're taking it on board at the lower level. You can see the changes. So it's no point just saying it's a board job. No, it has to be filtered on God. Turn it on its head. And the other thing is, so that's one thing there. But what I'd like to just come back to is the 75 years of Windrush and 75 years of the NHS. And for me, if you keep doing the same thing, you're going to get the same results. My answer is, my question is, what have we done differently? We've put in so many different, what you can call it, programs, so many different things. It is not about putting in the programs. It is not about coming up with another system. It's about the mindset, behavior, and culture. And if people are not being held to account, then how are we going to address this? So my question is, why are we still working in silos? So we've got you're doing this morning, NS Confed is doing something. The whole world has waited until this month to highlight this. It is just like Black History Month. This agenda has to be every month, every day, everywhere, by everybody. It is like safeguarding. It's everybody's business. So how do we then, as big institutions, great institutions like yourself, Kingston, how do we collaborate with everyone to address this issue? Because I think there's a lot of silos working. We have to come together to say, how do we address this together as we do? Because I think that is where we're having some of the issues. And you're right, some places are doing very well, some places not doing so well. So I'll just throw that in the mix. Some of it is questions, some of it is just my thoughts, but there's still a lot of work to be done. And I think we have, as Cheryl and my other counterparts have said, we have been chipping away. But 75 years later, when you look at the themes coming out from the international recruit nurses and the themes of 75 years ago, why are we still having those themes? Thank you.
Great. Thank you very much, Paulette. So quite a few issues and questions from Paula and Marty there, but I think what combines both is, what does accountability really mean? And that could be accountability at an organizational board level. It's also kind of individual accountability. It could be professional accountability, but a kind of a really strong sense, I think, from both Paulette and Marty about the frustration of, does accountability feel real here, or how could it feel real? So I wonder if I can get the panel's perspective on that round of questions. There was much more in what we heard from Paulette and Marcia as well, so I might ask for wider reflections as well if we have time. But I think that this key question about, what does accountability mean? How can people have confidence and trust that there is accountability and consequences? It feels like it's quite a recurring issue. There's a few bits in Slido on it as well. So almost where to start. Cheryl, I'm going to come to you first, just because you're not muted, so you don't have to press a button.
Yes, the word accountability, it's so crucial, because we see over and over again that for the perpetrators of unfair treatment, of discrimination, are never punished. And in some cases, they've actually been promoted. So if that is what staff are experiencing, how can you develop trust? And if we need to recognize the importance of having a workforce that feels confident, where that feels valued, that feels that their voice is being heard, because how you are as a worker is going to affect your the work, the service that you're going to be that you're delivering. And at the end of that, we have patients. And how is the outcome of any organization is reliable on the person at the grassroots level. So we need to get that right. We need to ensure that their voices are heard and that they have the confidence to raise their concerns, to raise their uneasiness to a higher level, and to know that when they raise their concerns, it is going to be acted on, and acted on appropriately, so that, you know, they feel that their needs are being met.
Right, thank you, Cheryl. I think I'll come to Charles next. So Charles, what would accountability feel like for you to trust that it was real?
Yeah, thanks, Sally. I think we've had lots of contributions around workforce. So I'm going to shift it back to community. And I think accountability is for people who have paid their taxes to know that they can access, you know, they can pick the phone, ring their GP, go into an A&E and be treated with dignity. You know, and for me, that is what accountability looks like. We have been behind, and we need to improve on an ethnicity monitoring. You know, with the changing demographics, working at ICS footprint level, we need to understand our, you know, communities and those we're there to serve as a National Health Service with all the amazing ethos we have. I think we need to be reviewing our complaints system as well as the complaints we're receiving. Who are those complaining? If we are told that, you know, as migrants, you should be grateful that you have free care, and therefore, you know, you shouldn't have anything to complain about, I think that's really disrespectful and inhumane. So who is complaining? And those complaints that are coming through, what are we doing as a result of that from a you know, service provision perspective? I think the other thing we saw from the pandemic as well, coming to accountability at board level, senior leadership, is the disproportionate death of people from ethnic minority or global majority backgrounds. Because, you know, you had people who were looking after two homes here and their home country. Therefore, you know, they were put in really dire positions without the appropriate equipment. We're not talking much about that. That racism, that discrimination, it is still rife. We're still dealing with that. And how structurally we're going to ensure that, God forbid, another pandemic happens across our health and social care workforce, we're not seeing the disproportionality or the discrimination. And some of these, whether it was medical doctors or nurses, sadly, disproportionate deaths to us.
Okay.
I think, you know, some of those structural issues needs to be tackled, because there were complaints about PPE and it not fitting, you know, once again, going back to the point of who we are seeking to serve. And I think trust is so crucial if we to improve, you know, access to services. The reason why people from my community did not want the COVID-19 vaccine is not because they were not learned. It's because the lack of trust historically, nobody's really engaged them. Nobody's treated them with respect. Nobody have said, okay, maybe you come from a background where you didn't have a free system. You rely on herbal remedies. Now you hear this is what's on offer. What are your concerns? How might we reassure you? And what we've done from my organization is use Caribbean African doctors, nurses, and other healthcare professionals to give confidence back to people as a way of rebuilding trust so they can access the free NHS that we've all contributed to, that we all love, and is the envy of the world. Thank you.
Right, thanks, Charles. So I'm going to come to Shilpa and then Habib on this question about what would make accountability feel and be real, and that can be organisational, individual, professional level. And then Patricia, just to clarify, I've clocked that you've got your hand up, so I'll come to you probably for our final question. But Shilpa and then Habib on the thoughts on accountability.
Sure, thank you. So I in terms of sort of how there could be sort of better or stronger accountability on this issue of race inequality. I just think if the sort of questions asked by government, by NHS England, by others about, you know, finances and quality, if the question about culture and race inequality was asked just as frequently as those questions about financial performance, about quality, etc., I think that could signal how it's not a side issue or a separate issue. It is a mainstream one. And, you know, perhaps these newly formed integrated care systems, they could ask themselves, how are we doing? How are we, you know, what have we done to promote anti-racism in our system, and make that a part of their regular kind of feedback to themselves.
Great, thanks, Shilpa. I think an important point about how we make sure that there is a full range of issues are being given airtime and challenged by boards, by senior leadership teams, and it's not just about the operational crises. Habib, your thoughts, please, on that.
I'll be very quick, Sally. I think, and I'll be to the point. Accountability isn't there on racism. Otherwise, we wouldn't be having this conversation today. And at an individual level, I think this agenda should be built into the annual appraisals of everyone, from the chief executive all the way down, who works in the NHS. At an organisational level, the regulators need to be a lot stronger in their positioning on racial inequality. It cannot be right that a hospital trust is rated as outstanding when a significant number of its staff are reporting bad experiences within that organisation, and yet that's happening. So, you know, we need to do a lot more on this, and it goes back to the point that Charles highlighted, trust. Because if we are in the business of building and rebuilding trust coming out of the pandemic, and we know that trust has become a new determinant of health, then we need to be able to demonstrate how we, as an organisation, as an institution, as an individual working in the NHS, are really taking this agenda seriously. And without accountability, that will not happen.
Okay, thank you, Habib. Really helpful reflections from all four of you on that key question of accountability and trust. Patricia Carlisle, I was going to come to you. You probably will be the last question. So Patricia, over to you. Hopefully you can turn your mic on, turn your camera on if you'd like as well. Are you there, Patricia?
Hi there.
Hi.
Sorry. So yes, I'm a lecturer in social work at Queen's University in Belfast, and I've just really enjoyed listening to the conversation and dialogue. And I suppose my question, is really about, so Northern Ireland is quite we do have some ethnic diversity, but we are quite mono. So we're and that's a challenge from an education point of view. And I'm just listening to the themes that you're talking about, and I'm thinking about practitioners, so within education, health and social care education, and thinking about how we can begin to instill an anti-racist message, and how we can begin to instill that that education piece. And you know, I suppose I want to share a little bit in terms of my own background. It's been a very white background. You know, we didn't have ethnic diversity within our schools, and this is quite so it's almost like if we scratch the surface a little bit harder, I know that there would be racism and significant issues, but they have maybe yet been significantly unearthed. And it's just that education piece about how we how we motivate that, or how we instill that in a way that is equipping and empowering both for the workforce and the service being delivered.
Great, thanks, Patricia. I think I might come to Habib for a first question, because it feels like you're sort of where we were in England sort of several years ago in terms of how do you create the space to enable the exploration, the scratching of this issue. How do you ensure that people feel safe to speak about their experience and that experience is heard? Because actually I'm sure there will be significant difference of experience already within your system, and it just might not be being heard. So it kind of feels like it's probably quite a lot of learning from the progress that we've made here. So Habib, do you want to share some thoughts on that?
Yeah, sure. So I think the first thing to say is that the NHS is diverse. So even when I think about England, even in the kind of the deep southwest where I live, where the general population isn't as diverse as other parts of the country, we know that hospital trusts, the NHS, employ a diverse workforce. But at the same time, we know that organizational diversity is not a precursor to inclusion, and therefore the experiences are not always great. And so in places such as parts of Scotland, Ireland, and even some parts of England and Wales, where the population isn't as diverse, very often it's those areas, those organizations within those areas that need the support as much as where there is diversity. And so what we're doing within the NHS Race and Health Observatory is thinking about, again, those causes of the causes. So looking at diversifying education, looking at what gets taught, what doesn't get taught within undergrad degrees, what features within textbooks in terms of skin color and different conditions, etc., and what doesn't, looking at diversifying research, what's focused upon in terms of research topics and who leads the research in terms of diversity. The very first piece of work that we did was to look at racial bias in pulse oximetry. And of course, that's a universal issue for people with more melanin in their skin. And so it's about looking at, how can we tackle, have those conversations, be comfortable with the uncomfortable, and tackle the root causes of the systemic biases that are inherent within our policies and our processes and our behaviours.
Thank you, Habib. And I think also this is an important reflection on some of the comments from Paulette earlier about organisations working in silos, that actually there is a lot of learning happening right across all 4 home nations. So how can we make sure that learning is shared when people are at different stages? Countries are at different stages, organisations are at different stages, individuals are at different stages, but being able to share what techniques and approaches have worked, how do you build trust and confidence that the talk is real, is, I think, really interesting. So we are kind of coming to the final couple of minutes. Unfortunately, the time has always flown by. I always think at the start of these, 1 hour and a half, this is going to be really long, but then it flies by. So, and I do want to make sure people have got a couple of minutes before meetings start at 10 o'clock. So I just want to say thank you so much to Habib, to Charles, to Cheryl and to Shilpa for your contributions today. I think from both your opening remarks and then from your responses to the questions, it feels like we've had a really honest conversation, a challenging conversation, but also at times a hopeful conversation, and a recognition that we can all of our organisations can help turn that hope into a different future. So I feel it's been a really fitting moment to mark the anniversary by mixing the honesty about the past, but also that hope about the future. So thank you so much. I just wanted to mention a couple of things to our audience, and I should also say thank you to our audience for joining us today and for a great set of questions. So a few things for many of you to potentially dip into and follow up. So tomorrow, as I mentioned at the start, we're publishing our library online exhibition about the Windrush generation and the birth of the NHS, and actually Cheryl is one of the people interviewed for that, so you'll get to hear more from her during the exhibition. So please do dip into that. It uses a mixture of interviews with past and current staff working in the NHS and oral history testimony, as well as we've delved into the King's Fund archive for materials as well. So we hope that will be an interesting and rich exhibition for people to dip into. Also to flag to colleagues that the Florence Nightingale Foundation Windrush programme, the next round of that is currently being launched. This is a programme that's funded by NHS England for nurses and midwives from a global majority background, and Cheryl